one of my very clever, now anaesthetic colleagues, that I was thinking of specialising in paediatrics. And they said, oh my goodness, why on earth would you want to do that? It's all just wheezing, fitting, and I'm not going to swear, we'll say gastroenteritis. But essentially, if you can master wheezing, fitting and gastro for paediatrics in the emergency department, you will be able to manage most of what comes through your door. I'd love to say it's far more varied, and of course there is diversity in that, but really the core presentations we need to know in detail. And to start with wheezing and childhood asthma, I thought I would talk to you about just two areas within asthma that I think might be useful to you, or I hope are useful to you. Firstly, I'm going to spend some time talking about the recognition and management of severe and life-threatening asthma. And that's really thinking ahead to your exams and what I imagine might come up, and giving you some evidence links to relevant literature that you might want to have a look at in preparation for that. Particularly, I want to talk about utilising severity scores in the emergency department, and also the new guidelines for management of children with asthma, and now that we're in the coronavirus pandemic. It doesn't look like coronavirus is going to go away anytime soon, so we need to adjust our management strategies with that in mind. And then we'll have a pause, and at that time I'm going to give an opportunity for us to have a short discussion or any questions regarding the first section of the talk, and then go on to talk a little bit more about discharge planning and what may not be totally relevant for your exams, but certainly will be extremely relevant to your future careers in clinical practice, I hope. Let me put childhood asthma into context for you. There was a worldwide prevalence study conducted between 1996 and 2002, and that surveyed over 1 million children. It's the largest prevalence study done, and it's a huge study, but very helpfully, some of the local paediatricians here in Cape Town have summarised what it means for us in South Africa, and they tell us that the prevalence of childhood asthma in Xhosa Black African children is around 15% for 7 to 9-year-olds, and that increases to 20% by the time they're teenagers. Importantly, that prevalence is increasing. So in 1996 it was 16% and now 20%. So this is common, and you know it's common because you see it all the time in the emergency department. Interestingly, in South Africa, compared to the world, ranked about 25th for prevalence of childhood asthma, but unfortunately ranked 4th and 5th as far as morbidity and mortality associated with childhood asthma is concerned. And worryingly, and pointed out in this paper, half of the children with asthma in South Africa have severe uncontrolled symptoms, and a third of them have no formal diagnosis made. And this really suggests a lack of diagnosis, treatment and access to care. And importantly, although asthma is the most common chronic childhood condition, asthma exacerbations are preventable, and the goal of asthma management should be to be preventing exacerbations. I want to take you back to the UK for a moment to a case, just quickly. This is an 8-year-old girl who presents to our paediatric emergency centre with an exacerbation of her asthma, and she seems quite unwell, and it's deemed that she's going to need admission to hospital. She's given nebulizers back to back and some steroids, and as is often the trouble in the UK, we don't have any beds in our hospital available, and so we arrange transfers to another hospital for beds. I know that's not what happens here all the time, But that's the system there. So this girl was put in an ambulance on her nebulizers for a 1-hour transfer to another hospital that had the capacity to admit her. Sadly, on arrival, she had a respiratory arrest and died. And that's a preventable death. And in the UK, preventable deaths in children are taken extremely seriously, and there's a huge investigation then taking place. And it makes us all ask questions of our practice. And one of the things that was brought up here was this child's severity of asthma fully recognised at presentation? And she clearly had life-threatening asthma, but wasn't treated in that category. Now, severity scores, while they're boring, are extremely useful as objective measures of how to manage these children. And I think the danger with a common condition like asthma, where we see lots and lots and lots of it, is we can get a little bit blasé in eyeballing children across the room and sort of, you know, making a very subjective assessment, saying, oh yes, they're going to need nebs, they can come in, they're going to need to go to high care. But actually, there's been some really good studies done where they've shown very experienced consultant paediatricians and emergency medicine consultants videos of dyspneic children, and they've been asked to say how severe they think the condition is, and we're really bad at it, and I think we gain a lot from actually using a score, although it seems a little bit mundane. As well as acute assessment, the scores are meant to be used for reassessment as well. And what's interesting, I think, moving forwards is looking at disposition decision making. There's been several studies looking at predicting disposition based on an asthma score at 2 to 3 hours of initiation of treatment. And wouldn't it be great if a child comes in with their asthma, they get put on their nebs and their steroids, and 2 or 3 hours later they get rescored, and you know with some certainty whether they're going to be admitted or discharged, and you can then set the ball rolling for referrals forwards and clear out your emergency department quicker. Well, that's the theory. Severity scores are variable, there's so many different ones, and if you read the literature you'll see that's very frustrating because you can't compare outcomes, so everybody uses something different. But the most widely used clinically practical severity scores are those from the British Thoracic Society. And these really we know, I'm sure you are all very familiar with. The only thing to mention, of course, is peak expiratory flow. I've never seen a child come to the emergency department with their peak flow meter, and I don't think they're available. So that probably doesn't form part of our assessment, but otherwise we should be able to tick off most of that. Locally, I'm sure you're aware, there are new guidelines for the management of asthma in the emergency department with coronavirus in mind. The guidelines aim to reduce the requirement for nebulization and thus reduce the risk to staff. And these are the severity scores from that guideline, quite similar to the BTS scoring. Some important differences, so it's worth familiarising yourself with those. And then this is the guideline that's now supposed to be in use for managing children with asthma in the emergency department. And this is temporary while we're dealing with coronavirus. And you'll find this on your EM guidance app. I'm going to take us through a little bit of it, looking at the evidence to support the various decisions along the way. So the first decision you have to make is whether a child needs nebulizers or inhalers. And we're all very used to reaching for nebulizers, and so are the nurses. And that's not necessarily a bad thing. However, it's good to know that inhalers are as effective, if not more effective, in children than nebulizers when they're used properly. And there's a big Cochrane systematic review published in 2013 that will tell you, summarise the evidence for this. And people are often quite surprised by that because for some reason we think nebulizers must be more dramatic and work better. But that's really not the case. And so in this new guideline that's trying to reduce nebulization, it uses this evidence to say, actually, our severe asthmatics can be managed with a metered dose inhaler and spacer. And 10 puffs is the equivalent of 1 neb. So where you would give 3 back-to-back nebs in an hour, we're now giving 3 lots of 10 puffs of your inhaler and spacer. Now, this needs compliance. It needs compliance from the child and parent, but importantly, the problem I see with this is it also needs compliance from the nursing staff, because this is quite heavy for them, in that this can't just be left to the parent to administer if a child has severe asthma. This needs to be actually done with a medical professional assisting, and that's quite a lot more work than just putting a nebulizer on. So we need to be encouraging our nursing staff and probably doing this ourselves as well. But I do think it has some great advantages in using inhalers in hospital. I think this gives confidence to parents when you discharge them with an inhaler. One, confidence that they can use it, because after the initial few sets of 10 puffs, parents will be able to take over doing this for their children, delivering the medication. And they'll see that it works in hospital, and they'll then have more confidence that it's going to work at home as well. And you'll also have confidence that they know how to use it. So inhalers for severe asthmatics, and really reserving nebulizers only for life-threatening asthmatics. And I just want to go back, these life-threatening features on this list really are life-threatening. I think we'd all be very worried if we had a child with those features. So that's when you're reaching for your nebulizers at the moment. And considering that the air entry is so poor for these children, you really don't need to worry about overdosing as far as the salbutamol and ipratropium. So don't waste space or volume in your nebulizers with saline. It's 2 mils and 2 mils salbutamol ipratropium, and that's 3 nebs back to back. The next question is about steroids, and we're very used to using prednisolone in asthma, and that's fair enough. There's been used for many, many years, and it's fine. However, most of you will have seen children vomit following prednisolone, and you know that you have to give it for 3 days, and I'm not sure about the compliance at home with a medication that makes the children feel sick. And also it takes a couple of hours to work. Dexamethasone is a brilliant steroid, and we use it all the time for croup. And there's been some good, a good RCT there if you want to look at it, looking at using dexamethasone instead of prednisolone for an oral steroid choice. And really that it's just as good and better because it doesn't cause vomiting and you only need 1 dose. For the sake of our severe or life-threatening asthmatic, you're going to give oral prednisolone, but if the child is too unwell to take oral or vomiting, you can give IV dexamethasone, and it's 0.6 per kilo. There's a St Emmeline's blog. I know some people prefer to read, to look at blogs rather than journal articles. There's a link there to the blog if that's more helpful for you. And then really you're going to move on to the intravenous treatment options. And Peruki is a research network in the UK for paediatric emergency medicine. And they did a study of over 3,000 clinicians, asking them about their treatment regimes for status asthmaticus. And they found over 30 different treatment regimes used. And clearly nobody agrees on what's best, and that's because there really isn't that much evidence to support one way or another. Having said that, there is increasing evidence to support the use of magnesium, and interestingly on this guideline that's aiming to reduce the amount of nebulization required, alongside giving your steroids, it's suggested that you give an IV dose of magnesium sulfate. So magnesium we know works well, and there's lots of evidence to look at. Most of it's summarised in Cochrane. Be aware just a practical point, magnesium causes vasodilation, and you'll often see flushing around your injection site, infusion site. Don't presume that your Venflon's gone. Just check, because that is a normal side effect of magnesium. It can also cause hypertension, but I don't think that's ever really been clinically significant. So magnesium IV, great. Good evidence for it. And while we're on the topic of magnesium, you ought to be aware that there's been a significant RCT called the magnetic study published in the Lancet looking at nebulized magnesium. And the British Thoracic Society now recommend the addition of magnesium in those first 3 nebs for severe asthmatics. This isn't local recommendations yet, but I wonder in a few years' time whether it might come through. And again, there's a FOAMed summary of magnesium in asthma if you're interested. So back to our pathway. So we're basically now, having given our nebs or inhalers, we've given our steroids, we've given some IV magnesium, we're reassessing, and unfortunately things are not improving. We're going to move down to IV salbutamol. While you're giving IV salbutamol, you continue your nebulizers of salbutamol, just continuous salbutamol nebs. And salbutamol for IV is given in 3 parts. So you give your bolus, and then you're going to make up the infusion solution. And the loading dose is a 1-hour infusion at a higher rate. And then you reduce it down for a maintenance infusion. As you know, salbutamol causes tachyarrhythmias occasionally, so it's worth being on a cardiac monitor. And at this point, you ought to be reviewing your diagnosis. I think it's interesting that it's not suggested until now to do a chest X-ray and a gas, and I actually think that's right. Sometimes we waste a lot of time, and our focus is shifted by worrying about getting gases or X-rays early on in the treatment of asthma. At this point, though, if your treatments aren't working and you're looking at IV salbutamol, then you do need to be thinking, could there be something else going on? And things that I've missed in the past have been the sort of rather large pneumothoraces and inhaled foreign bodies can sometimes surprise you. So that's your IV salbutamol. And at this point, I'm never sure, new to Cape Town myself, your thresholds for involving your local paediatricians within your hospital, or whether you as emergency medicine liaise directly with PICU. But I think if you're down the road to IV salbutamol, you're going to be speaking to someone. And you're going to do a gas just now, and if you're hypoxemic on your gas, or if you've got a climbing or normal CO2, then obviously you need to be getting some advice. And the reason you need advice from PICU is that nobody wants to be ventilating asthmatics. It carries a huge mortality rate, over 20%. So you definitely need advice before jumping for a tube. Other things that you might have up your sleeve before then: adrenaline. We can give adrenaline as you would for anaphylaxis intramuscularly. And of course there is a role for NIV. I'm an advocate for high flow, just from my background, rather than CPAP. But that's a whole other talk, and I don't want to get into the details of ventilating asthmatics. Something for your interest, because it seems to be quite topical at the moment, is ketamine. We know ketamine is a great bronchodilator, and certainly if you do have to end up intubating a child with asthma, you're going to use ketamine as your induction agent. There are quite a few case reports of using ketamine as an IV bronchodilator, but the latest Cochrane sort of review is not supportive yet. So I just want to pause there. Sorry, I've rushed through a lot of that, but I'm sure it's mostly familiar to you, and really something that you can perhaps have another read through, or have a look at some of the links to the papers or blog sites at a later stage for yourselves, for your own reading. But I wonder, before we move on to talking about discharge plans, whether anybody has any questions or anything to add or they want to raise from what I've said so far. I don't know.
Jess, there is a hand. Cumlin has a question. Cumlin, can you please turn on your camera?
Yeah, I'm getting there. Just we won't be able to see because I put that thing in focus mode. Hi, Jess. Thanks for the talk so far. Just a few things on the salbutamol and stuff. So it's quite tricky here, and I found that we don't typically. I wouldn't want to start it without involving the PICU, especially in places like Tygerberg and G Ground, just because by the time you write up the order and the nurses have to make it and have to get it, it's quite a process. And then, as you mentioned in your slide there, the issue with the lactic acidosis, and then you start to figure out, you start to sit with the situation of, are they becoming acidotic because of the salbutamol? Or respiratory muscle fatigue, and it's very complicated. So my question is, what's the difference between starting your infusion of IV salbutamol versus your IM anaphylactic dose of adrenaline? And the reason I ask that is, especially when you're taking a referral from a periphery, and somebody sounds really sick on the phone, obviously they're definitely not going to start your IV salbutamol there. And if the adrenaline is given, can you still, on top of that, add IV salbutamol? I mean, obviously, it's very difficult because when somebody comes in sick, this stepwise stuff doesn't really work. It's usually everything at once. They're getting their magnesium and their high flow, and someone's preparing the salbutamol. But in terms of the salbutamol, sort of the beta agonist discussion between salbutamol and adrenaline in our setting, would you recommend one over the other, or is it always a PICU decision?
Thanks for the question, Camlin. I don't think it's always a PICU decision there. I think you guys can make that call. I would say certainly in district hospitals where they might not have access to, or in a community clinic, if you're on the phone to a community clinic and the child sounds like they've got a life-threatening asthma, all they can do there is NEBS. You're going to do no harm by suggesting giving a dose of intramuscular adrenaline, and I think that would be very sensible. I think the pre-hospital guidelines for life-threatening asthma in South Africa include IM adrenaline. So you may find that if children are being brought in by paramedics, they have already had a dose of IM adrenaline as well, so it's worth asking. So certainly, yes, I would say if in doubt, or if you think it's needed, give it. It doesn't mean that you can't then give salbutamol as well at a later stage. Does that answer your question?
Yes, thanks.
We have another question, if that's okay, Jess.
Yeah.
Dave, do you want to ask your question? Dave, you're going to have to unmute yourself first, bro.
There you go. Sorry about that. I've just got a question about asthma terminology. I know obviously below 2, we normally say it's bronchiolitis. After 5, we're happy to say it's probably asthma. But then in that sort of 2 to 5 range, everyone seems to have a different terminology for stuff. So some, there's multi-trigger wheezes, there's viral episodic wheeze, there's all of this stuff. I kind of get a little bit lost in all the terminology as to what, if somebody comes in with recurrent episodes of wheezing and they're 2 till 5, what should we call it? And at what point can we say this is now asthma, we should start putting them on something prophylactic, or this is probably just something related to recurrent viral urtes? Yeah, I'm not sort of very clear on all of that.
I'm really grateful for that question. I agree, the terminology is so confusing, and my training in the UK, we had this label of viral wheeze, which referred to children between sort of 2 to 5 who you weren't really happy to say were asthmatic, but that every time they got a cough, cold, virus, they would end up with a wheezy chest. And you would treat them with bronchodilators in the same way you would treat asthmatics. But on your rounds, you definitely weren't allowed to call them asthmatics because that apparently was not correct. And it was very frustrating. I think there is a general feeling that in that age group, between 2 and 5, there are around 90% or more of the children that present with wheeze have an intercurrent viral infection, and that is the trigger for their wheeze. And we know that those children are most likely to grow out of having recurrent wheezy episodes by the time they get to school, purely because they actually grow out of having so many viral infections, because your immune system is developing at that stage when you're at preschool. And so they didn't like to label all those children with asthma. Having said that, I think that the thinking around that is changing, because there's quite a lot of studies now to suggest that actually preventative medications such as inhaled corticosteroids are very beneficial for children with viral wheeze, as well as those children with asthma. And so actually it doesn't make a huge difference what you call it, because you're actually going to be treating them the same. Does that answer your question?
More or less. So would we never put those kids that are 2 to 5, would we never put them on a preventive steroid inhaler, because we would say that this is purely triggered by viral infection?
Even the wheeze triggered by viral infections. So that's what I was sorry, I didn't make that clear. So children that have wheeze that are under 5 years old, the wheeze that is triggered by viral infections, still get a great benefit from being on an inhaled corticosteroid preventer inhaler. So you would still prescribe them inhaled corticosteroids.
Okay.
Even if they don't have allergic triggers to their asthma, even if their asthma is just triggered by viruses.
Okay, so is there sort of a threshold you would use then, sort of like 2 or 3 or 4 episodes in a year, or would you do it based on the first one? Yeah, sort of, I guess, what would the threshold be for then us prescribing that to go home with?
You are jumping ahead to the whole second half of my talk, which I'm really grateful for. I'm going to cover this. I'm just so happy that you've raised this, because I didn't think it would be something that you might be that interested in, but I'm going to cover that now.
Okay,
if
cool.
there aren't any more questions.
Thank you. That's great. Thanks a lot.
Any more questions about the acute side?
I don't see any more hands. Does anyone have any more questions? If not, I think we're happy to carry on.
Okay. So I've saved the second half of my talk for what I really wanted to talk about, which Dave has actually highlighted. And that's the plans at discharge for these children. So it's pretty clear who we're going to admit. And I think we have clear parameters of who we're going to discharge as far as their symptoms and observations go. Just remember that children under 5 may still be wheezy when you discharge them. That's fine, as long as they're comfortable, they're not recessing tachypneic, and they're saturating well. You don't have to get them wheeze-free. But I think those parameters we're all very comfortable with. I just want to show you this picture. This is a picture of 2 newly qualified emergency medicine consultants. Obviously a few have lost hair from, must have been the M-Med, or anyway, there they are, hard at work. And I want to go back to the initial study that I highlighted to you, that's been published by the, well, not a study, it's a paper written by some local paediatricians in response to that global prevalence survey report. Half of the children had severe uncontrolled symptoms. This was a huge number of children. A third had no formal diagnosis made. And that really does suggest a lack of diagnosis, treatment and access to care. And as I've said, but I'll reiterate, asthma is a chronic condition and it can be controlled to prevent exacerbations. And exacerbations in childhood have a huge effect. So there is a tiny risk of death. There's a more significant health risk of repeated oral steroid use in children, and be aware that not everybody writes in the Road to Health card, and these children often get sent, they go to one clinic, the next clinic, the hospital here, the hospital there. Not always clear if at every time they're getting a course of oral steroids, suddenly they are actually at risk health-wise. We know that childhood asthma uncontrolled affects sleep and all the after effects of lack of sleep for children. We know that parents attending hospitals and clinics will lose money as they're not at work. And importantly, maybe most importantly, we know that children spend more time sat at home wheezing than they do sat at school learning. And the people that wrote that initial paper kindly, as well as telling us that there was a problem and they wanted a call to action, actually followed through and provided their idea of a solution. And if you read one paper from all of the references that I've included in these slides, I'd really encourage you to read this one. This is something that I think you will learn most from, as it's probably not what you're most familiar with at the moment working in emergency medicine. But it talks about inhaled corticosteroids, and as Dave's highlighted, we need to have a few criteria as to when we should be prescribing these. And it's clearly set out there. So an asthma attack in the past 2 years that's required bronchodilators and systemic steroids. So that's quite a lot of children that you see, I'm sure. If they're using their salbutamol inhaler more than twice a week, or if they're having symptoms of nocturnal cough or shortness of breath, wheezing more than twice a week, or if they're waking up with their asthma symptoms more than once a week. So those questions should be part of our initial history taking for a child that presents with asthma. And I say ours because I'm actually speaking to you guys as registrars. You're going to be consultants in a few months or years' time. So these may not be the questions that you're asking, but on your round, these are the questions that you need to be asking your junior doctors and encouraging them to be eliciting in their history taking. Helpfully, that paper has also provided the doses for children for inhaled corticosteroids of the commonly available steroid inhalers in South Africa. As you know, you're supposed to advise that these inhalers are given before they brush their teeth morning and evening, or at least wash their mouth out afterwards, because they're at risk of oral thrush with this. So we go back to our safe discharge plans, and I'm afraid there's a lot more to do other than just checking that a child is not tachypneic or assessing and saturating well. We have a responsibility to educate parents around the use of their medication, and provide stop smoking advice, and prescribe our maintenance therapy, give them their plans for their exacerbations, and arrange follow-up. Also, antihistamine use. So we should be prescribing antihistamines for children to take regularly, especially if they have allergic triggers identified for their asthma, or if their asthma seems to be worse in summer rather than winter or the pollen season. And if you are going to prescribe an antihistamine, please can you prescribe cetirizine rather than Allergex. Chlorpheniramine or Allergex is associated with drowsiness, and there's been some really good studies looking at how children do poorly at school who are prescribed those medications because they're half asleep in their lessons. So cetirizine is the antihistamine. And then you need to arrange follow-up, and your acute episode can be followed up around about a week in the local clinic if possible. And then they do need a maintenance review for their maintenance therapy if you've prescribed inhaled corticosteroids. And that can be at the local clinic, Or if that's actually not feasible and you've got a POPD, then at a POPD centre. I think right now, I think I'm just going to go on to this. I just want to say to you that we're in a pandemic, and even if we're not, but particularly in times of pandemic, you'll find that parents are bringing their children to hospital or to clinics less. They'll be less engaged with healthcare, and our opportunities for intervening become less frequent. And I don't think that prescribing preventative treatment or thinking about preventative treatment is beyond the scope of emergency medicine physicians. So we really all have to do our own part for children. And I just want to leave you with the idea of making every contact count when you're dealing with children in the emergency department. I'm going to leave it there and just say thank you for your time. Please look after each other and the children. I know these times are hard for everyone. And I'm happy to take questions or have a discussion with you now about what we've spoken about, or I'm also happy to take emails if anybody wants to get in touch. That's my email address.
Thanks so much, Jess. That was a lovely talk. Does anyone have any questions? I have a question, if it's possible.
Yeah.
I just wanted to ask, in terms of your severe asthmas, we know that with severe asthma, we need to call our paediatrician quite early. The question is actually for those moderate asthmas who possibly, if they don't get their inhalers or their nebs, depending on where you are, if they don't get them fast enough, obviously there's a chance of them deteriorating. In South Africa, with our busy emergency centres, it's a high likelihood that they're probably not going to get their continuous nebs, 3 continuous nebs for an hour. Would you prefer that we call the paediatrician early, just knowing that a moderate can possibly deteriorate into a severe asthma? Or would you prefer that we actually watch them for an hour prior to us calling you out for every moderate asthma that we have?
I think we have to. I think that depends on where you are and the preference of your local paediatricians. But what I would say is, if you feel that your demands in your emergency department are such that you are overwhelmed with the trauma or COVID or whatever it is that you are dealing with, and you are stretched to the point that you can't actually keep your eye on or manage the asthmatic that's arrived, then speaking to a paed and getting support early and just explaining that actually, you know, you're busy with the gunshots and there's an asthmatic here, and you know, would they like to come down and see that asthmatic? If you're asked in a way that encourages sort of teamwork, that I'm sure they'd be very happy to do that. As far as, I'll just go back to the moderate, as far as the mild to moderate asthmatics go, these ones definitely you're going to be managing with inhalers, not nebulizers. Even if we're not in COVID times, I really think we should be managing children with inhalers as much as possible. As far as sort of educating parents and getting children used to their inhalers in the hospital environments, it's more likely they'll use them probably at home. So your moderate asthmatics are going to be on inhalers. I think you can always give the plan, you know, to the parents as well as the nursing staff for a bit of backup in the delivery of that. But I agree, it's a real challenge. And I think, and this is no criticism at all, but what I've observed happening is that an asthmatic child will come and will get seen and quickly, and a neb will be prescribed. And then somebody will get busy and go do something else and then come back a few hours later and they're still wheezy, and another neb, maybe some steroids will get prescribed. And then that person has to go off and do something else again. And then by the time they get back, it's the end of the day and they're like, oh, it's still wheezy. And so they'll have to be, we'll have to keep them overnight and prescribe, 2-hourly nebs or something, and a lot of that is, I think, down to people's experience as to what they feel then they're comfortable prescribing. But it would be good to actually make a treatment plan sort of from the beginning to actually give more treatment earlier on, rather than this sort of dripping nebs in throughout the day. Let's give them the inhalers, let's give the 10 puffs 3 times in the first hour, and then reassess an hour later, see if they need that hourly or if they need that 2-hourly. I think you'll find it's easier to get them out of the department that way, as in home. And remember, at the moment for your severe asthmatics, you're going to be giving IV magnesium as well as your steroids. So those ones are going to need to stay, presumably. I don't think we're comfortable discharging patients having had IV magnesium. I think you would probably get RCP'd for their input there, perhaps. Maybe some people are comfortable with that. Does that answer?
Yes, it does. Thank you so much. Does anyone else have any questions? I think I saw Cumlin, did your hand go up, or was I seeing things?
No, it was an accident. Sorry.
Oh, sorry. Anyone else? And Jess, just one last question from my side. Sorry, guys, I have lots of questions. The last question is just in terms of the inhalers and the nebs. I know a lot of the emergency centers actually don't have spaces, and a lot of them actually don't have inhalers, and parents don't come with their inhalers in their bags. They've left it at home or whatever it is. Is there a suggestion on your side in terms of actually trying to fight for a change in terms of getting the emergency centers to stock their inhalers, or do you think it's fine for us? I know that it hasn't proven to show any benefit of a nebulizer over inhaler, but would it be easier then for us to just continue with the nebs rather than trying to get all these spaces and these inhalers?
What I tended to do is write on my TTO, send the mother off with the TTO to the pharmacy to get the inhaler and the spacer and the mask when they arrive. Then they can bring that back, and then they can use that in the department while they're there. That's one way to get around that. Otherwise, yeah, I think we should be fighting for inhalers, especially with coronavirus around. We shouldn't be unnecessarily nebulizing children.
Great, thank you. Anyone else? If not, thank you so much, Jess, for your talk today. We really enjoyed it. And I think that is it, if there are no more questions. I think Lauren does have an announcement for everyone. So can I just ask everyone to just stay on for us?
Jess, thanks so much for the talk. That was great. It was so informative, and it really unpacks a lot of the questions that I had in my mind. Perhaps maybe I could just ask you 1 or 2 questions. And it's just around, we know that the arterial blood gas sampling on children is really distressing for both the child and for the parents, probably also for the healthcare provider. And so what would your recommendations be in terms of the frequency of repeating gases to kind of get an impression of a trend?
Okay, so firstly, I don't think we should be doing arterial blood gases on children until you're at the point of prescribing your IV salbutamol infusions. And thinking about discussions with PICU or the need for ventilatory support. So I don't think a gas guides your management at all until that point. So hopefully that means not too many gases done, because I'm really hopeful that most children will have responded before you get down here. But if you are then putting children on salbutamol infusions and you've done a gas, I think you can look at your clinical parameters to see whether things are improving, and those would be so you're in the life-threatening category if you're on the IV salbutamol. So when you reassess, you can look and see, do you still have one or more of those features? The gases, I don't think we should be repeating gases. I think you do the gas, you see what your numbers are, then you've got to make a call and have a discussion with your PICU colleagues. And then if you choose to ventilate a child with asthma, then that's a different story, of course. But as you know, ventilating asthmatics, you're going to be using a heavy amount of sedation. So hopefully the trauma of the gas sampling once you're ventilated should be minimal. So yeah, in a nutshell, I think you do one gas when you're at that stage of your IV salbutamol. Realistically, what's going to happen is you're going to talk to PICU, and someone in PICU is going to say, oh, okay, keep doing what you're doing and call us back in an hour with a repeat gas, because that's what happens while they try and work out advice from their seniors or transport plan. So I think, you know, if they're then giving you that advice, fine, you have to take the advice if you've asked for it, really. But personally, I don't advocate repeating gases unless something clinically has changed significantly. Is that clear?
Yeah, that's great. Thank you. The other question is, at what point do we start thinking about covering empirically with antibiotics?
Yeah, the jury's out on antibiotics in asthma. In the UK, it's almost unheard of prescribing antibiotics for children with acute asthma. And then I came here and I read some awful post-mortem reports for children and the amount of bacterial pneumonias that are around, and where children have accessed healthcare with respiratory complaints in the previous couple of weeks. It's a huge problem. I think if you've got a life-threatening, anything life-threatening in children requires antibiotics, whatever symptom or medical condition it is, you're going to cover with a broad spectrum antibiotic. Otherwise, look, I think you need to go on your history. If there's a setup for an infection, then of course go for antibiotics. But I don't think it should be routine. I don't think they should be routinely prescribed for children who present with asthma attacks. Even the little ones who've, you know, they've all got viral infections. So yeah, my answer would be no, unless you've got a life-threatening asthmatic, in which case broad spectrum antibiotics would be indicated.
Great, thank you very much. Yeah, guys, I really encourage you to reach out to Jess to have discussions on this kind of topic. She's open to engaging with you. She is an incredible wealth of knowledge, and actually has a fair amount of experience in our local centres. So for those of you who have an interest or just need some clarification, I'd really encourage you to reach out to Jess. Thanks, Jess. Have a lovely day, and hope to welcome you soon. Welcome you again to our session soon.
Pleasure. I hope it's useful for you.
Definitely.